Welcome to the e-textbook of echocardiography. In this module, we are going to discuss about the assessment of various systemic veins abnormalities. Systemic venous abnormalities are a broad range of spectrum that ranges from very minor asymptomatic anatomic variation to extremely complex abnormalities that can lead to cyanosis or that can complicate surgical repair of congenital heart diseases. Whenever the visceroatrial situs is well lateralized as a very clear-cut situs solitus or situs inversus, clinically significant abnormalities of systemic veins are not common at all. However, in patients who are having visceral heterotaxy or situs ambiguous, the incidence of systemic venous abnormalities is very high. We should analyze the systemic veins in every patient with congenital heart disease. All the components of systemic venous abnormalities can be identified very clearly on echocardiography. Echocardiographically analyzing the systemic veins will be with 2D echo imaging, followed by color flow imaging, and sometimes use of agitated saline injection in the arm veins or leg veins to find out the drainage of the systemic veins. Analysis of the systemic veins will start with evaluation of the inferior vena cava. Normally, the hepatic veins converge to the last part of inferior vena cava before it drains into the right atrium. This can be confirmed from subxiphoid coronal sweep, where we can appreciate the entry of the hepatic veins into the inferior vena cava. On a subxiphoid sagittal view, we can notice both the superior and inferior vena cava entering into the right atrium. On color flow Doppler, we can notice the inferior vena cava entering into the right atrium. The normal inferior vena cava has got a good inspiratory collapse. During the inspiration of the patient, the negative intrathoracic pressure causes a sucking in of the blood from the inferior vena cava into the right atrium, and this results in collapse of the inferior vena cava. Identifying this inspiratory collapse of inferior vena cava ensures that the vena caval pressures and the right atrial pressures are within normal limits. In patients who have elevated right atrial pressure, or in other words, in congestive heart failure, the inspiratory collapse will be reduced. Evaluation of the superior vena cava is done from the suprasternal view. When we keep the transducer in coronal plane, we'll be able to appreciate the innominate veins joining together on the right side to form the right superior vena cava. The innominate vein will be seen to course transversely immediately below the transducer in the suprasternal window. On color flow Doppler, we see the innominate vein joining the right superior vena cava. In some of the patients, the left innominate vein may course below the aortic arch and behind the ascending aorta, and this will be described as retroaortic innominate vein. Both the innominate veins will be joining together to form the right superior vena cava, in this instance at a slightly lower plane. We need to appreciate this abnormality because the left innominate vein may sometimes be misinterpreted as the right pulmonary artery in cyanotic heart diseases, and a wrong assumption can be made about the pulmonary artery anatomy. We can appreciate the color flows in the retroaortic innominate vein on color flow Doppler. In Situs inversus totalis, the inferior vena cava lies on the left side of the spine and the abdominal aorta to the right side of the spine. This can be appreciated from the subxiphoid view when we keep the transducer in a coronal plane. In Situs inversus totalis, both the innominate veins will converge towards the left superior vena cava and the right superior vena cava will be absent. This will be the mirror image of a normal systemic venous drainage. When we use color Doppler, we can appreciate the innominate veins joining together to form the left superior vena cava in the setting of Situs inversus totalis. Let us move on to clinically significant abnormal systemic venous connections. Some of the venous anomalies can clinically cause cyanosis. Some anomalies can complicate the procedure of cardiac catheterization and the procedure of transvenous spacing. Some of them may force the surgeon to alter the surgical strategy of cannulation while going on cardiopulmonary bypass. Some venous anomalies can alter the surgical steps, like performance of a Glenn shunt or a Fontan surgery. Some of them may be involving the coronary sinus. There are a lot of venous abnormalities that are commonly associated with heterotaxy syndromes. We will discuss all of them. Systemic venous abnormalities that result in cyanosis can manifest with central cyanosis without a clinically observable cardiomegaly or cardiac murmurs on auscultation. This can be seen when there is a left superior vena cava that is draining into the left atrium with absence of coronary sinus. It can also be seen when the right superior vena cava anomalously drains into left atrium, or the inferior vena cava anomalously drains into left atrium. Sometimes there can be total anomalous systemic venous drainage with drainage of both the right superior vena cava and inferior vena cava into the left atrium. However, these are very rare. The venous abnormalities are quite important for the surgeons to know about. Before venous cannulation during cardiopulmonary bypass, all the venous abnormalities should be analyzed. If there is a left superior vena cava without any bridging innominate vein, the left superior vena cava will need a separate cannulation during cardiopulmonary bypass. Sometimes in the very small baby, this may even involve going on total circulatory arrest. If there is a large bridging innominate vein, it will allow LSVC ligation or clipping. While planning a Glenn or Fontan surgery, if there is an LSVC with no bridging innominate vein, we may have to perform a bilateral bidirectional Glenn shunt, which means anastomosis of both the superior vena cava to the respective pulmonary arteries. In the presence of inferior vena cava interruption with azygous continuation, if a Glenn shunt is performed, this would result in a total cavopulmonary shunt with direction of the inferior vena caval blood also into the PA, and this will be described as the Kawashima's operation or TCPS. There can be some venous abnormalities involving the coronary sinus which are of clinical significance. If there is a coronary sinus ostial atresia, the coronary sinus becomes decompressed by a persistent left superior vena cava. In such cases, if we divide or ligate the left superior vena cava, this will result in catastrophic effects due to lack of coronary sinus drainage to any cardiac chamber. Unroofed or absent coronary sinus is common in heterotaxy syndromes and in common atrium associated with Ellis-Van Creveld syndrome. In these patients, the left superior vena cava should be baffled towards the right atrium. While planning cardiac catheterization, these venous abnormalities should be clearly be assessed. If there is an inferior vena caval abnormality, an elective jugular or subclavian vein approach will be needed for performance of certain procedures like pulmonary valvotomy. If there is a left superior vena cava draining into the coronary sinus, pacemaker implantation may be done from the right side. This is a cartoon of different forms of persistent left superior vena cava. In the first picture A, which is quite commonly seen, the left superior vena cava drains into the coronary sinus and ultimately into the right atrium. In many of the patients, there will be a persistence of a bridging innominate vein also. Sometimes, the right superior vena cava can entirely become absent and the whole of the venous drainage from the upper half of the body will be through the left superior vena cava. Both the innominate veins will join to form this left superior vena cava, and the left superior vena cava will finally drain into the right atrium. In some patients, there can be unroofing of the coronary sinus, and here the left superior vena cava may directly drain into the left atrium. Some of these patients with left superior vena caval direct drainage into the left atrium may have a bridging innominate vein. On a subxifoid coronal sweep, in the long axial view, we can appreciate the dilated roofed coronary sinus entering into the right atrium. This dilated roofed coronary sinus receives the left superior vena caval flows, and we can appreciate it clearly from very high parasternal or suprasternal echo windows. We can see in this example the blue flows through the dilated coronary sinus, which is completely roofed. On a transesophageal echocardiogram in the 0-degree plane, after appreciating the mitral valve apparatus, if we advance the probe a little deeper into the esophagus, we will be able to appreciate the dilated roofed coronary sinus on the posterior mitral annular groove. The normal coronary sinus that receives the left superior vena cava will have a measurement much more than 1 centimeter. If the coronary sinus is receiving only the coronary veins and there is no persistence of the left superior vena cava, the coronary sinus often will be less than 1 centimeter in size. It will become much larger whenever it receives the left superior vena cava. When we inject agitated saline through the left cubital vein, we can appreciate the contrast entering into the right atrium through this dilated coronary sinus. In patients who have bilateral superior vena cava, we need to identify if there is a bridging innominate vein. In this example, we can appreciate that there is no bridging innominate vein at all. When there is no bridging innominate vein, the right superior vena cava will drain directly into the right atrium, and the left superior vena cava will drain through the coronary sinus again into the right atrium. In the same example shown in the previous slide, we can notice the flows in the left superior vena cava draining towards the coronary sinus. Sometimes left superior vena cava can directly drain into the left atrium when there is a complete unroofing of the coronary sinus. Here we can appreciate the left superior vena cava draining in the roof of the left atrium, adjacent to the left atrial appendage. On color flow imaging, we can appreciate the flow of the blood from the left superior vena cava directly into the left atrial cavity. The coronary sinus is the venous structure that drains all the coronary veins. In patients who have persistence of the left superior vena cava, the left superior vena cava also drains through this coronary sinus into the right atrium. The abnormalities of coronary sinus can be the coronary sinus ostial atresia. In these patients, there is often an unroofing of the coronary sinus within the left atrium, and so all the coronary sinus blood will find its way into the left atrium. Since the quantum of coronary sinus venous return is very low, this may not result in clinically significant observable cyanosis. A cartoon is shown in figure A. However, if there is no unroofing of the coronary sinus in the presence of coronary sinus ostial atresia, the coronary sinus will be decompressed by a persistence of the left superior vena cava, where the blood flow will be reversed and the flow will be directed towards the left innominate vein. In these patients, if we ligate the left superior vena cava, it will result in coronary venous drainage impairment. In some patients, as shown in type C, there will be an unroofing of the coronary sinus as well as persistent patency of the left superior vena cava. In these patients, the left superior vena caval blood will flow through the coronary sinus into the right atrium, and the unroofing of the coronary sinus will also allow flow of the blood from the left atrium into the right atrium through this unroofed area of coronary sinus. This abnormality is described as the coronary sinus type of atrial septal defect or Raghib's type of atrial septal defect. Since the flow of the blood is from the left atrium into the right atrium through the unroofed portion of the coronary sinus, it is grouped under the heading of atrial septal defects. In coronary sinus ostial atresia, the coronary sinus cannot drain into the right atrium. So the coronary sinus gets dilated on the posterior mitral annular groove, and it can be seen from the apical four-chamber view. This is a magnified view of the posterior wall of the mitral annulus in the apical view, where we can appreciate a large and dilated coronary sinus. However, it doesn't have any entry into the right atrium. In the same patient with coronary sinus ostial atresia, when we come to the regular four-chamber view, we can appreciate the dilated coronary sinus just above the mitral annulus. With color Doppler, we will notice that the dilated coronary sinus is not entering into the right atrium at all due to coronary sinus ostium being atretic. From a suprasternal view, we can appreciate the flow reversal in the left superior vena cava. Since the coronary sinus ostium is closed, all the coronary venous blood should be decompressed by this left superior vena cava into the left innominate vein. A still frame from the suprasternal view which shows a flow reversal in the left superior vena cava. Whenever this pattern of a red flow is seen in a vein that is draining into the left innominate vein, there can be various clinical possibilities. Number 1, a coronary sinus ostial atresia with the coronary sinus being decompressed by a persistent patency of the left superior vena cava will allow the coronary sinus blood to be draining into the left innominate vein, and there will be a reversal of flow. Number 2, it can be due to a partial anomalous pulmonary venous drainage of the left upper or lower pulmonary vein into the left innominate vein. Number 3, it can be due to duplication of the inferior vena cava, where a left-sided inferior vena cava ascends up as the hemiazygous vein and continues as the left vertical vein and ultimately drains into the left innominate vein. Fourth reason can be a levo-atriocardinal vein, where the left atrium will drain into the left innominate vein to decompress itself. This will be seen in patients who are having cardiac sinister, or in other words, divided left atrium, or sometimes in congenital mitral valve atresia or mitral valve stenosis. These are all the various reasons for reversal of blood flow in the left superior vena cava. An angiogram of a coronary sinus ostial atresia is shown here for the sake of better understanding of the complete anatomy. Let us move on to a clinically more interesting abnormalities described as the coronary sinus ASD or Raghib's ASD. This entity is also described very well in the module on atrial septal defects. In this subziphied coronal view, we can appreciate the right and the left atrium and the intraatrial septum. In the lower portion of the intraatrial septum, we can see a dropout in the intraatrial septum and blood flow from the left atrium into the right atrium. We can also notice superiorly a large venous channel that is entering the roof of the left atrium, which represents the left superior vena cava. The abnormality in this heart is a persistence of the left superior vena cava and a complete unroofing of the coronary sinus. This results in the left superior vena caval blood to enter directly into the left atrium. However, since the ostium of the coronary sinus is open, that allows the blood to be shunted into the right atrium through the ostium of the coronary sinus. So the ostium of coronary sinus in this patient acts as an atrial septal defect to allow the blood from left atrium into the right atrium. This defect is called as coronary sinus ASD or Raghib's ASD. On a subziphied sagittal view, we can notice the normal drainage of the right superior vena cava into the right atrium. The entire atrial septum is seen to be intact except in the most caudal region, where there is a flow of blood from the left atrium into the right atrium. This region is the ostium of coronary sinus, and the ostium of coronary sinus acts as a coronary sinus atrial septal defect. On a subziphied long axial view in a coronal plane, where we can appreciate both the superior vena cava draining into the respective atria, we can notice this venous abnormality very well. We can see the right superior vena cava draining into the right atrium and the left superior vena cava draining into the left atrium due to lack of coronary sinus roof formation. On a frozen still frame from the subziphied long axial view taken in a coronal plane sweep, we can notice the left superior vena cava directly draining into the left atrium without any roof of the coronary sinus. From the suprasternal view, we can notice the flow of the left superior vena caval blood towards the left atrium without any coronary sinus roof formation. On the contrary, an example of a patient with left superior vena cava which is draining through a roofed coronary sinus is shown in this example. Here we can appreciate the left superior vena cava draining into a completely roofed coronary sinus, and we can see the final opening of the coronary sinus into the right atrium. The right superior vena cava can sometimes anomalously drain into the left atrium, and this will clinically result in central cyanosis. In these patients, there will be no observable cardiac enlargement or clinical cardiac signs like murmurs. On a subxiphoid sagittal view in the short axis plane, we can notice the inferior vena cava draining normally into the right atrium. However, the superior vena cava is seen directly draining into the left atrium, posterior to the plane of the atrial septum. On this subxiphoid short axis view, when we utilize color Doppler, we can appreciate the flow of the right superior vena cava directly into the left atrium, posterior to the plane of the interatrial septum. On an agitated saline contrast echocardiogram, when we make an injection in the cubital vein, we can see the flow of the agitated saline through the right superior vena cava into the left atrium, and there is no filling of the right atrium. On an apical view, we can appreciate the agitated saline injection filling directly the left atrium and left ventricle, and not the right atrium and right ventricle. Similar to the right superior vena caval drainage into the left atrium, which can result in clinical cyanosis, persistent patency of the left superior vena cava into the left atrium will also result in clinical cyanosis. This is a suprasternal view which shows a persistence of the left superior vena cava, and the left superior vena cava directly drains into the roof of the left atrium. On a color flow Doppler interrogation, we can notice the flow of the blood from the left superior vena cava directly into the left atrium. This will result in clinically significant cyanosis. Very rarely, an abnormal connection of the systemic veins can be seen after surgery. This may be occurred due to a surgical misconnection. In this patient who had a sinus venosus atrial septal defect treated by a patch closure of the ASD, an abnormal routing of the superior vena caval blood towards the left atrium is resulting in flow of the superior vena caval blood towards the left atrium and causing clinical cyanosis. On an agitated saline injection through the cubital vein, we can notice the flow of the blood through the superior vena cava, which drains into the left atrium, posterior to the plane of the atrial septum on this transesophageal long axis view. Another example of a patient with large secondum atrial septal defect, which has been patched abnormally, that results in the superior vena caval blood flow getting wrongly connected towards the left atrium. We can notice the flow of the superior vena cava posterior to the plane of the atrial septum in this long axial bicaval view. On a color flow imaging, we can notice the superior vena caval blood directly entering the posterior left atrium on this bicaval transesophageal echo. Again, on an agitated saline contrast injection from the superior vena cava, we can see the flow of the blood into the left atrium. A similar surgical misconnection can happen with inferior vena cava also. Here in this example, the atrial septal defect patch has been sutured all along to the rims of the eustachian valve. This resulted in the inferior vena cava to drain posterior to the atrial septal plane towards the left atrium. Sometimes the inferior vena cava can get interrupted in the suprarenal portion, and the inferior vena cava may continue as the azygous vein towards the superior vena cava. This is commonly seen in heterotaxy polysplenia associated with left isomerism. In congenital heart diseases, this abnormality is seen in about 1 to 3% of the patients. Absence of inferior vena cava between the level of renal veins and hepatic veins result in this IVC interruption. So the hepatic veins directly drain into the right atrium, and the infrarenal IVC continues as the azygous into the superior vena cava. On this subxiphoid view, when we keep the probe in the coronal plane, we can appreciate the spine and anterior to the spine, the abdominal aorta. We can notice a venous channel on the right side of the aorta in the paravertebral gutter, and this venous channel is clearly posterior to the abdominal aorta. This represents the azygous vein. We can also notice that the liver is occupying the midline, and this is a feature of left isomerism. The way to identify an inferior vena cava, in contrast to the azygous vein, will be the position of the venous channel in relation to the abdominal aorta. Inferior vena cava will be anterior to the abdominal aorta, whereas azygous vein will be posterior to the abdominal aorta. We can notice in this subxiphoid view that the azygous vein is on the right paravertebral gutter. We can also notice the abnormal position of the right side of the stomach. The liver is in midline in this patient with left isomerism. On a color flow imaging, we can notice the venous flows in the azygous vein and an arterial pulsatile systolic flows in the abdominal aorta. On a subxiphoid sagittal plane cut, we can appreciate longitudinal course of the azygous vein. The venous flow is blue because the flow is from below upwards towards the superior vena cava. On a subxiphoid short axis view, when we see the right superior vena cava draining into the right atrium, on the posterior wall of the right superior vena cava, we can appreciate the azygous vein draining into the superior vena cava. This azygous vein will be dilated. On a color flow imaging, we can notice the flow of the blood from the azygous vein into the posterior wall of the right superior vena cava. Since the azygous vein drains into the posterior wall of the right superior vena cava, if this patient has to undergo a bidirectional Glenn shunt with anastomosis of the superior vena cava into the pulmonary artery, this will result in total cavopulmonary shunt. The inferior vena cava blood and the superior vena cava blood will all drain into the pulmonary arteries after such a shunt. This will be called as the Kawashima operation. The dilated azygous vein, which courses in the right paravertebral gutter, will be draining the entire venous return from the lower half of the body except the hepatic veins, and this whole of the venous return from the lower half of the body will be directed towards the superior vena cava. The lower end of the right superior vena cava, immediately above the SVCRA junction, will be dilated because it receives not only the right superior vena cava blood but also the inferior vena cava blood through this interrupted IVC and azygous continuation. IVC interruption with azygous continuation is more commonly seen in patients with Situs ambiguous, heterotaxy, and left isomerism or polysplenia syndrome. In this situation, both the atria have got features of left atrium. So both the appendages will have left atrial appendage morphology. Since coronary sinus is a part of left atrium, in patients with polysplenia syndrome, if there is a persistence of patency of the left superior vena cava, there will be a well-formed roofed coronary sinus in all these patients. On the contrary, in situs ambiguous heterotaxy with right isomerism, which are often associated with asplenia, the inferior vena cava will be patent and the inferior vena cava will anatomically lie immediately anterior to the abdominal aorta on the same side of the spine. There will not be a lateralization of the position of inferior vena cava and abdominal aorta in patients with asplenia and right isomerism. In this subxiphoid sagittal view, we can appreciate the inferior vena cava directly anterior to the abdominal aorta. This feature is very common in right isomerism. In these patients with right isomerism, both the atria will have the features of right atrium. Since coronary sinus is an integral feature of the left atrium, in patients with right isomerism, if there is a persistence of the patency of left superior vena cava, the coronary sinus will often be absent and the left superior vena cava will directly drain onto the left-sided atrium. Duplication of the inferior vena cava is an abnormality characterized by presence of two inferior vena cava on either side of the spine. The right inferior vena cava drains the right iliac veins and the right renal veins, courses superiorly, drains all the hepatic veins, and ultimately enters the right atrium. The left inferior vena cava drains the left iliac and left renal vein, ascends up as a hemiazygous channel on the left paravertebral gutter, and ultimately drains into the left innominate vein. We can see in this suprasternal view the presence of two superior vena cava and a large bridging innominate vein. The left-sided superior vena cava is in fact the continuation of a duplicated IVC through the hemiazygous channel towards the left innominate vein. When we do a color Doppler interrogation of this left superior vena cava, we can find a complete flow reversal because it is draining the whole of the left half of the inferior vena cava towards the left innominate vein. In the same suprasternal view, when we assess the color flows in the right superior vena cava, the flows are normal. Whenever there is a flow reversal in the left vertical vein into the left innominate vein, as shown by a red colored flow on the suprasternal coronal plane sweep, the reasons can be in IVC duplication with flow of the left-sided inferior vena cava blood towards the left innominate vein, or an anomalous pulmonary venous drainage of the left upper pulmonary vein to the left innominate vein, or it can be due to coronary sinus ostial atresia with decompression through the left superior vena cava. It may be due to decompressing levoatriocardinal vein in cautery atrium or in congenital mitral stenosis or atresia. It can also represent sometimes the dilated first intercostal vein with flow into the left subclavian or left innominate vein. To summarize, systemic venous abnormalities should be identified in every echocardiogram that is done for evaluation of a congenital heart disease. It may vary in spectrum of severity. Some of them can lead to cyanosis. Some can pose problems for surgery and cardiac catheterizations. Some can have surgical implications, and it is very important to recognize these abnormalities.